I'd like to introduce everyone. This is a subject I guess we haven't put any attention to in the last couple of years for sure.
Correct.
And although individually we all have worked, what we have is a distinguished psychologist who really has helped us individually, but it'd be nice to have him talk to us today in general about some of the things we've done. In his biography, internship, clinical psychology intern, Temple University, neurophysiology, Temple University. It has been published. He's been working. You know, this is a friend. I don't have to go much further. However, one of the things I do want to put out is that he has already published an article or a lecture called Finding Our Way from the Heart to the Head. We probably are going to be touching on a couple of those things today, and I'm so happy to have him today.
It's a pleasure being here, seeing everybody today. Thank you. I'll try to keep this as generic as possible, short and sweet. Our attention span is somewhat limited, so mine too.
Why are you looking at me?
You need more light.
Well, my involvement goes back a couple of decades. I've evaluated over 2,600 end-stage heart failure patients to date. The average age being about 51, but the age range has been 16 to the upper limits of 70. It's about 4 to 1 male over female. It used to be 5 to 1, but the females are catching up. 55% of the folks that present are have an ischemic cardiomyopathy, and it's in keeping with the national trend. 23% that I have followed have had neurologic events, and this will be important as part of the presentation today to keep this in mind, that it's almost 1/4 of the population has had a neurologic event. By that I mean strokes, mini strokes, significant concussions, brain tumors, aneurysms, etc. So 1/4 of the population presents with a neurologic issue. 90% have no advanced directives, living will, or power of attorney, which makes our management very difficult when we don't have an adequate spokesperson. And to date, I've been involved. Yesterday was the 200th device, and over 628 transplants between Temple and Prominent over the years. Well, there's some promising alternatives on the horizon, with over 500,000 patients in the United States presenting with end-stage heart disease. 8% are currently being maintained on IV inotropic support. There's estimated from 80 to 150,000 patients in need of a heart transplant. It's quite a large group, with only 2,200 being transplanted yearly. Also on the horizon is the new support from devices, the bridge to transplant devices and the destination therapy devices. The purpose of the destination therapy is primarily for use with those people that don't qualify for a heart transplant, but obviously want to continue with life-sustaining measures, and either because of age or other physical comorbidities don't qualify. These life-extending options are presented to us in the way of continued medications, that it's inotropic support. You've all been on inotropes, you know what that involves and what it entails. Bridging support with LVADs and RVADs, ventricular assist devices. Destination therapy. Transplant is certainly an extended life option. And then also artificial hearts, which are also being developed more. Some of the dynamics at work that are driving this force that help with life extension are twofold. It's obviously on the patient side and then obviously on the staff side. Patients come in, they're more desperate. They hear and see more options available beyond medication, so they want what can be provided for them. Like everyone else, they feel entitled to the best. They feel as though they deserve the best. And they have a zeal for life. And it's a renewed zeal for life once they start feeling better, either during the management of their heart failure or after device support or transplant. On the staff side, we have great expectations from the patient as well as the family. High expectations. We have expectations from the referring doctor. They want their patient obviously to do well, and that's why they come to a major medical center. And we have a fleeting window of opportunity in order to help people. It doesn't stay stable, it moves, sometimes it increases, more than likely it decreases over time. So we have to use time-appropriate measures to help with life-sustaining support. With respect to my involvement with transplant and devices for bridging or destination, I get involved with taking your history. Any of you that have come into Hahnemann Hospital have seen me or the students with me, and we're very interested in your history and background because that gives us a very good indication of what we can expect after device support or after transplant. The best prediction of behavior is behavior. You're not going to change at an average age of 51. So what we hear and what we see from your history tells us who you are going to be for the next couple of decades. We do a mental status exam, very important because of the neurologic implications and neurocognitive implications. Having, again, repeating myself, having seen that almost 25% of the people are coming in with neurological problems in the past, very important. I meet with the family almost always, unless you don't have a family. We do cognitive testing on folks that are going for bridging to transplant or destination therapy as part of the FDA requirement. And bedside follow-up while you're in the hospital and upon readmission. Well, some of the identified threats to neurologic integrity are probably part of your history. Sudden cardiac death certainly is a big one. People present during a traumatic period, and often during sudden cardiac death they experience anoxia, which is a brief cessation, slowing or stopping of blood flow to all organs, including the one up north. Hypoperfusion, that is decreased amount of perfusion throughout your body. Arrhythmias, ventricular tachycardias, and atrial fibrillation is very much a part of the threat, neurologic threat. We know that VT and atrial fibrillation has a propensity to want to throw little clots. And the clots like to go north, but they also like to go east and west and south. Your past medical history may include diabetes or chronic renal insufficiency. These are also threats to cognitive integrity. Previous cardiac surgery, cabbages, vascular assistance, and so on. Time on and off cardiopulmonary bypass pump plays a role. We know that it's been identified in the past as playing an intimate role with your cardiac and cognitive functions. Stenosis, toxic agents. The medications that you were taking prior to transplant or prior to bridge support, I'm sure you felt as though were affecting you, and you're right, they have been affecting you, but the benefit certainly outweighs the risks, and we need to consider the benefit from these high-level inotropic supporting agents. Metabolic instability, it's not just your brain that's not working, it's your kidneys, it's your liver, multiple organs are involved. And again, the past medical history of CVAs and mini strokes, TIAs.
What's a CVA?
Cardiovascular accident. CVA.
I don't know.
Okay, cardiovascular accident, cerebral vascular accident.
Health literacy, it's my passion. Why?
What are some of the ideas? Why do we think that there's been cognitive impairment in heart failure patients? Well, certainly due to cerebral infarction from a shower of microscopic emboli in your heart when it's not working properly, or when there's atrial fibrillation or ventricular tachycardia. And then again, ischemia, that is a slowing or cessation of blood flow throughout the body, including the brain. We have the benefit of taking a look at a very large study, European study, and recognizing that cognitive impairment and mortality have a very close relationship. In 2 European studies with over 13,000 patients, we identified 3 critical variables. One is systolic hypotension clearly is associated with cognitive impairment in older patients with heart failure, older, basically in their 6th decade, that is 50s and above. Inpatient deaths with cognitive impairment are as high as 18%. It's very high. Those without cognitive impairment are only 3% likely to demonstrate mortality. Outpatient death is 27% with a group that has had cognitive impairment or identified with neurological problems. That's very high. And no cognitive impairment is 15%. So the idea is to be treated as an inpatient with no cognitive impairment. No identified cognitive impairment. These impairments usually involve memory functions and learning, attention and concentration, which we all are privy to, problem solving, language disruption. It may not be a stop of language use, it may just be a temporary loss of language function or a change in language function. Processing speed is probably one of the more critical features. That is your ability to manage multiple tasks at the same time. It's slow work. It has slowed down as a result of cardiac deficits. And then also reaction time and motor speed. You're not who you used to be by virtue of your cardiac concerns, but also by virtue of age.
Yeah.
We do find that once you're transplanted, your reaction time and your motor speed improves, and that's about the only function cognitively that does improve. Memory, learning, processing speed may improve, but not significantly.
I don't know, my Jeopardy skills are still not very good. I always think of the answer after the answer.
Well, you're in the KID category.
But aren't these the same problems that you would have with Alzheimer's or?
Yes, yes.
So you really don't know?
Well, it's akin to a vascular dementia,
Yeah.
vascular disruption. What are the psychosocial factors that are influencing your outcome? And these are the things that we pay attention to in the hospital, that all the team members pay attention to, but we focus on primarily. And you may not appreciate the value of identifying these, but it helps us identify how we're going to manage you in the future. So I'm listing for you what the psychosocial factors are so that you won't demonstrate them. Obviously, non-adherence is a big one. That is maintaining your medical regimen, your follow-up, behaving yourself with your doctor, your cardiologist, and your surgeon, meeting your appointments, and so on.
What cognitive impairments can we actually see in ourselves or in our cronies or whatever at this age group well and above the 60s?
Well,
Is it evident, or do you have to evaluate us on a one-to-one basis, or?
well, there's a common trend in folks in their 7th decade and their 60s. Perhaps we can bring this up and talk about it at the end.
I'm sorry.
Yeah, no, that's okay, but I think it's germane and maybe tied together at the end. It's a good question. When we see that there are authorities involved with our supervision, authorities being legal authorities or court-committed authorities or folks that are mandated to care for us, that's always a concern. No established support, having no support system, no family, no loved ones, no significant others. Males are the biggest offenders. Single males do not do well, we know that. Females do well because they have an established network of support which they've learned to do and establish, maintain, and establish, usually beginning in their early teens. Chronic neurologic history, as was mentioned earlier, is important. Comorbid psychiatric history that's not been attended to, that is, you haven't paid attention to taking your medications or follow-up, psychiatric follow-up for bipolar disorder, major depressive disorders, high anxiety, and other related psychiatric features that tend to disrupt compliance and follow-up with the heart failure clinic. Obviously, suicidal, self-destructive, assaultive, and impulsive behavior plays a big role. All of you are solid citizens, but we don't come across solid citizens all the time, so it makes a big difference. And substance abuse, we have obviously a lot of substance abusers that come through. A lot of the cardiomyopathies are due to substance abuse, cocaine, alcohol, marijuana. Continued use of substances tends to produce cardiomyopathy, and as well as IV drug use. Recidivism, what do I mean by that? Recidivism means you fall in and out of what's expected of you in terms of trying to remain sober, either alcohol or drugs, other substances. When you have a pattern of being on the wagon and then off the wagon and then being on the wagon again, it's not a good predictor for us, because we know that once we load you up with immunosuppressants and steroids, your tendency to go off the wagon is really high, very high. Personality disorders. No one in this room has an Axis 2 personality disorder. Personality disorders are interpersonal, severe interpersonal problems. And since you're married to the transplant center or the medical site, it has to be a good marriage. And if you're having interpersonal problems, the nurses feel it, the doctors don't, and the surgeons don't, cardiologists and surgeons don't feel it first. It's everyone else that attends to the patient that sees it. Nurses on the floor, nurses in the outpatient clinic, and last but not least, the surgeon and the cardiologist, although most cardiologists and surgeons have become very sensitive to this and very perceptive.
Couple of examples of that.
Sure. Folks that are very disruptive on the floor, blaming everybody, not satisfied, being irritable, verbal abuse on the floor with the staff, that kind of stuff. Verbal abuse is very likely in a hospital setting. In fact, it's 10 times more likely with a hospital staff, because they're nurturing and caring and are perceived as being submissive and tolerant, and folks come in and feel as though they can abuse the staff, and that's not tolerated. Fragmented families, families that are not together. There's a lot of conflict and disunity in the family, discord, a lot of strife. Well, if you're coming into our facility and you're expected to be married to us and compliant, and you carry on with us, we're going to know that because you've been carrying on with your family. And the lower down would be poor occupational pursuits, learning or perceptual problems because it interferes with your ability to comprehend more complex information and learn information in a smooth, facile, cooperative manner. Maladaptive behaviors. Behaviors that have not gotten you anywhere as an adult. Abusive, verbally abusive behaviors, problems with the law, difficulties with authorities, these are maladaptive behaviors. And general poor coping ability. Probably the first 7 or 8 are probably the most important. Okay, so what interventions are made in a way of trying to help you get started for change during your heart failure as well as after transplant? We know that being honest with yourself is primarily of primary importance and a big concern. You have to be honest. When many of the heart failure patients come in, they're only honest when they get real sick and they need help and they're desperate. However, they've been less than honest with their family and friends prior to this. So we expect you to be honest with yourself if you want to make change, and that you are able to adequately self-assess. I'm not happy with what I'm doing. It's hard for me to describe what I'm doing wrong, but I know something's not right. I feel as though I could do better. I have a sense of remorse, perhaps, for what I've done in the past. Setting attainable goals. Don't try running the Broad Street Marathon if you haven't tried it, if you haven't warmed up to it, if you haven't run a mile or two beforehand. So you need to do it in a reasonable fashion, and it must be attainable, something that you feel that you can accomplish. Reorganizing, we're all a little self-centered. Part of being healthy is being self-centered, but reorganizing that so that you learn to redirect your care and maintain your care is important. Learning to address some of the cognitive limitations and your emotional differences are also important. So, learning how to adapt and adjust and take on new stress management areas for yourself. That is perhaps sleeping more, or taking on a little bit more exercise, or spending more time with the family, things that you enjoy, maybe getting back into your hobbies, areas that can absorb the stress rather than aggravate it, things that make you feel better. Recognizing change will produce stress. I'm trying to take an Italian course, and it's very stressful. I recognize it as being stressful. But I'm stumbling along, and I'm learning slowly, and I recognize that it's a major intrusion in my life because I'm trying to fit it in. All of us go through a process of going sideways or going backwards in our progress. We need to establish a strategy so that when we go sideways or backwards, we can get ourselves back on track. It's not a matter of if we go sideways or backwards. It's a matter of when we go sideways or backwards. Habits and behaviors are hard to change, so that you can expect that you'll try to bring those back at some point to test it out. But it doesn't get you anywhere, so you need to establish a strategy so when you do go sideways or backwards, you get yourself back on course.
Easier said than done.
It's very, very difficult, but these are the things that adults throughout life learn to do with challenges over a period of time, and we're foolish if we don't educate ourselves about the mistakes that we've made in the past and try not to make them again. Yes, easier said than done, that's true. And it's a very complicated issue with medical problems. What are some prerequisites for changing our behavior? Well, keeping in mind that change occurs slowly, it doesn't occur overnight. You might want to give yourself a couple, 3 to 6 months to make some mild changes, not 3 to 6 days or 3 to 6 weeks. And it occurs in our head, not in our heart. Just because we have a new organ or organs doesn't necessarily mean that we're going to be our new person and the change will occur automatically. Monitoring your behavior through journaling, discussing it with other people that are significant to you, watching your sodium and caloric intake is very important, as the nurses tell you. Learning to monitor yourself is extremely important. And then also maintaining your support system. You don't want to alienate the people that love you or are close to you or the significant others. Alienating them isn't going to help. I think this might work. Some concrete things that you can do to modify your behaviors is think of going from a disabled mode to an able mode. I'm able now. I'm more able than I was. I can ambulate. I have more energy. I can go up and down stairs. I can enjoy life. I can travel. You know, I can spend time with the kids. I couldn't even have my grandson or granddaughter sit on my lap before because I was afraid my ICD was going to go off. I was going to have a heart attack. So it's important that you see yourself in a more able condition. Commit to working on one new healthy interaction. So you don't choose 1 or 2 or 3 or you don't choose more than one healthy interaction. If you have been likely to be withdrawn, you want to be more social. You may want to participate in church or participate in more family-related matters to help commit yourself to that new healthy interaction. And perceive yourself as going through a gradual transition, not a rapid transition. You weren't born in 2 weeks. It's not going to develop in 2 weeks. It took at least 9 months to get you where you were at birth. So think of it in terms of a projected, long-term projected project. It's not going to happen overnight, fortunately. So practice one small change at a time. Don't practice multiple changes. We encounter folks that want to go back into bad habits like drinking too much or smoking too much. When you're encountering some bad habits after transplant or with device support, be honest with yourself, ask for help, so reach out to significant others, and try to approach one small modification at a time. You're not going to stop smoking overnight. For those that have returned to smoking, and women are more likely to return to smoking than men, unfortunately. So try to do this slowly and at a modest rate. I think that's it. Thank you. Thank you very much. Now, can I address the cognitive issue? I think that's important, and especially in folks in their 60s and on. Normally in our 40s we experience a gradual, normal cognitive decline, right? Beginning in our 40s. So it began to slip way back when. It didn't just start. Is it more than normal? Probably not. In the cardiac group, probably it is. It's just a little bit outside of normal range because of the assaults that you've taken and the insults that your integrity has taken in the past, vascular, in terms of vascular insults. So the major component of someone in their, major feature of someone in their 60s and 70s are certainly going to be more than the normal memory changes, being more forgetful, or the family notices you're more forgetful. That's when you really begin to pay attention. Or you start repeating yourself because you don't recognize that you've already said that. You might have been thinking it and said it, but don't remember that you said it. You're in trouble. So it doesn't mean that all the bells and whistles go off. It just means that you're just falling outside the normal expected range of cognitive.
Is that at the moment or is that long range?
Long range. Yeah, long range. And keep in mind that you're on some offensive agents, or have been on some offensive agents. The inotropes have affected you. The immunosuppression, especially the steroids, corticosteroids, affect you. It's a known antagonist to memory over long periods of time, not just a couple of weeks, not just a couple of months. When we're in the hospital, they put you on a high level of steroids, high. I mean, most people are uncomfortable at 2. You're on 80 to 100 for, the first week, and then they gradually bring you down. But even on 40 or 50 at home, when you go home, there's a lot. It can disrupt a lot of things. It disrupts your appetite, disrupts your sleep, your libido, you're irritable, you're moody, you cry. There's all kinds of things that happen to you at 40 milligrams. When you're sustained at 5 over long periods of time, it still affects you. Corticosteroids are a known offender to memory functions, processing speed, your ability to be as quick as you were. Now, we're not as quick as we were when we were in our 30s and 40s, obviously, and you're expected to slow down, but you're not expected to be a turtle. You're expected to sort of conduct age-appropriate activities. And assuming you do, then it's fine.
Doctor, if I may, one of the things I recommend, and I'll tell you why, but let me put it this way. Because of my background as a technologist, I found that I attempted to handle issues the same way as I did. And it was only by coming to you, you said, Jim, do not handle issues in your stomach, because if you do that, and the reason I came to you then, because I really blew. I mean, I was trying to handle things, and one of the things you told me is that, look, tell people, what is it about what I said you don't understand? You told me to be very political about it, and not be, and so forth. However, if they don't understand, just push it on them. And over the last 5.5 years, I've learned how to do that. And believe me, it has kept me cool or calm, or whatever the case is. And the other thing is, and that I learned from you is, because being technical, I didn't like to make mistakes. Because that was my job, not to make mistakes. And I remember you telling me that it is okay to make 10 mistakes a day, but don't count. I remember those things. And from that, I always recommended that during the first 6 to 9 months for everyone, heart transplant or recipients, to come and make an appointment to see you so you'll know what's going on and so forth. And the reason for that, because one of the things you said is, you don't know who the real you actually is at this time. Because that past 18 years was not really the real you. And going forward, that's someone else. So therefore, you have to learn who that person is. And believe me, I learned a lot from you.
I'm laughing because one of the things that you told Jim that I remember, Doctor, is that I was not his employee.
That's right.
He went from working very hard, right, and almost into transplant. And he didn't have a group to manage anymore. I was going to be in. No way.
And he told me to, you got your kids and your wife to manage, and then a few weeks later you told her that, look, you're not his employee anymore, let him do his own.
It's when you brought out that performance where you failed.
And failed. But and one of the reasons why Renard and myself want to get you, because it was so important, when you speak of psychological and mental and so forth, sometimes unless we get support from you or direction, we don't know what's going on. And you become irritable inside, and you really don't know. And I really recommend it very highly to come.
Well, that's a good point. It's a very confusing period when you're going through all these medical changes.
I also think it depends on the background, as Jim said, where he came from. Well, I was a nurse, so when I came into it, I read everything, I knew everything, I handled everything a lot better because I knew what was happening and knew what was coming down the line. So I think that can make a big difference too, because you were like this and this, and I said, oh, I know this is happening. Okay, let's do this. And like I ended up like Post-its were my best friends. If you you write a note and so you don't forget what you're doing, you have your Post-its.
Sure. Yes.
Two things I'd like to share with everyone. When I was hospitalized and listed for a transplant, because prior to that, I had extreme stress, not health stress, but in my business. After I got the transplant, that stress was compounded in that same area. I didn't have time to worry about my health. I felt good, but I was healthy enough to address it. And so I never really had any stress over the health situation. I just did what I was supposed to and handled my other stress. And the other thing is, the comment you made about compliance while you're in a hospital or anywhere with the medical team. I had a roommate for 4 months. It was the worst patient I ever saw. I think the nurses drew straws who was going to care for him. He sent some of them out of the room crying. And they shared their grief with me. And they paired me up with him because I was the only other patient that would put up with him. He didn't make it.
I want to go into just a little, unfortunately this morning, I recognized myself almost 18, 20 times. I didn't even bother looking at you. Thank you for that. We should have had you at least 6 years ago, because these are the things that come out. But I want to talk about something about the brain and the ability to control your behavior from an emotional. We know that stress is just an umbrella name. Everything is stress, but you have to break down that stress to a certain level to understand it and know what. And we cannot know what to do with it, but there are certain things that happen. Emotionally, if something, some kind of a crisis or whatever comes up, and you react in an emotional way, you know that somewhere along the line you have to handle that emotion to go into it, and so that you can look at something in a practical, normal, everyday manner. And now, what do to try to react with logic and reason when this emotional thing is happening, and you know darn well that you're adding whatever stress we have stress all the time, but the one thing that comes is in a crisis mode, what happens? So I'm asking, how do you control it? How do you get the emotional way so that you can work with things in a practical manner, especially?
It's hard to be logical when it's overridden by emotions. Putting the moment aside, putting it in a position so that you can attend to it later emotionally helps you deal with the logic that's required. Stepping away from it. It's you learned this when you had children, when they told you, when you feel like taking a swat at your child, to step away. Mothers learn this. Move yourself out of the moment so that your emotions can reorganize and settle down, so that you can begin to approach it logically and not emotionally. So obviously identifying it and then stepping aside or putting it aside is important. You have a bad day, something's aggravating you, you have to make important decisions. You don't want to combine the two. You want to be able to put the emotion aside and then address it. But you have to identify it to do that. Or ask for help in identifying it, like your significant other. Honey, something's wrong with me. I don't know what I'm doing. I'm confused or whatever.
I mentioned the stress I had, business related, and one thing that I did, Bernard, I was fortunate to have enough knowledge of the laws involved with the things that were stressing me that I could prioritize and not try to do a dozen things at once. And that's the only way to solve the problem.
Right, right.
There is one way that I found in trying to solve the problem was to write everything down. In fact, I kept a diary for 4 years. And also based on my background, I will research some of the things and look at what is happening to me. But what that did for me, it's put me in a position to talk with the doctors on an intelligent basis rather than just asking a question. I'll say things like, this is my understanding. And some of the nurses or doctors say, yeah, your understanding is from what you got on the website, didn't you? But actually it helped me understand what was really going on to a degree.
Well, you're dealing with it in a different mode. Once you write it out on paper, or once you put it aside physically, or prioritize it, you're trying to change the mode, which is important. It takes you away from the emotion and the affect.
Right.
Because at that point, physically, you're just overwhelmed, and it's very difficult to sort things out. And you need to be able to do that. The anatomy will always override any of the logic.
I understand.
It will always override the logic that's needed to solve the problem. So you have to put that aside, the physical part of it.
Well, I think the best thing are forums like this where you have patient-to-patient support, because I know I never wanted the moniker disabled, and so I had 2 full-time jobs, one paying my bills all day and one hooking up to a dialysis machine for 10 hours every night for 4 years. And it wasn't until I joined a support group that I felt like, oh, okay, those steroids, my emotions are right underneath my skin, right? And why am I eating so much? And why am I so irritable? And things like this. But it was I got my care that I felt like I needed is through, other patients, talking to other patients. And, but it was so hard to ask for help because I felt like if I started asking for help, I was starting to fail, and I was going to become disabled, where I was going to need more caregivers or what have you. And I was trying to do it all by myself, living by myself, doing those 10 hours of dialysis. And then it was, my friends were like, you're not failing if you ask for help, And so that's when I started to work, try to get a different flexible work schedule and this, that, and the other thing. So I wasn't failing. But I couldn't have gotten through all of it without, a patient forum. And I tell everybody that's going through an evaluation for a transplant, no matter what organ that they're waiting for, is, talk to other people, and I give out my cell phone. I've given out my cell phone to thousands of people, so. But I think it's true. I know, I'm like, I hope I never go into a restaurant on the New Jersey Turnpike and I see my cell number on the back and stuff. But it's just, I feel that important that, we've received these gifts of love and we're paying it forward and helping other people, so.
Doctor, in reply to Renard's comment, when he's confronted with the immediacy of conflict, I think the person that conflicts or has the last word always loses. Sometimes you just have to let it just sit and not reply, because when you're confronted with something, you want to say, hey, I'm going to tell you where it's really at. That's where it should end before that happens. But
right.
That's not easy when you're on steroids.
A good example of that is when you're on a road and someone aggravates you while you're driving. And that's happened with all of us. And can you stop and step back and not get in conflict? And can you just put it in sort of your head in neutral for a little bit until everything settles down? That's hard.
well, I guess there are various levels in these circumstances. I mean, I don't know how to exactly measure all of them,
Right.
but I'm sure there are times that I would fly off the handle, but I try to avoid confrontation.
Well, from where I sit, I see it as a trigger. So there's something that you're responding to because that's an annoying trigger to you that has happened before. It's occurred before. It's not just the first time that this has come up. Some of us have multiple triggers. Some of us have a couple that when we know we're pushed to the limit, there's going to be an explosion. So identifying a trigger is really important. whether you're a cardiac patient or anybody else, you get to know your triggers after a while. You should know your triggers.
You do, yes.
You know, my life experience before I had any health problems, I think helped me when I was driving an 80,000-pound vehicle and had to put up with all kinds of crazy people around me. I withheld my temper because I could wipe them out.
There's one other thing that when you came to see me in the hospital, you said that the things which could subliminally get to you, whether or not you're on the phone, watching television, listen to music, and it happened to me. I was listening to Johnny Mathis during Christmas, and I remember it was December 6th of 2006. And I'm not sure exactly which song he got to, but it's somewhere between 1 and 18. And I started feeling emotional. I took the medication I was supposed to take, went upstairs, said, look, something's wrong, and I started crying like a baby. And I said, and she got scared, actually, when she called the hospital. Because the only time I had cried in my life that I remember was when my mother-in-law died. I mean, even from a baby. But I said, there's something wrong here. But then I accepted it after I spoke to you, and I said, you know what? I'm human. I could cry. I hope I don't cry today, but and that's the thing that happens. It was something that me crying.
The song was Chances Are.
It was that. And what I did after that, I said, I am not going to let this beat me. I listened to Johnny Mathis all 18 songs later that night, and I was fine.
What about multiple triggers? You were saying, like, you get to know your triggers. And sometimes, you know, as you're going through some of these things, things just pop up that normally wouldn't set you off, and then just like, well, why is that taking me off? What is this? Just off the blue.
Well, we all have multiple triggers.
Right, you don't necessarily
recognize.
Right.
The idea is that if you're getting yourself emotionally upset, then you step back and say, why? The answer may not come to you at that moment, but if you pull yourself back and maybe later that day or the next day, it'll become more obvious to you. Look, you're all logical. You can reason this out if you can get the emotional response aside. Park it for a little bit, and then you can figure it out. But when you get it's wrapped up in your decision-making and your logic, it's going to get nowhere. In fact, it gets convoluted. It gets mixed in with a lot of things. And it's that mixture that gets you into more trouble later.
Is it true that people don't change, they just get worse?
With age. Thank you very much.
I found that many, if not all, heart transplant patients that I meet become very emotional very easily, including myself.
Well, it's mortality, it's steroids, it's end of life, and it's triggers. If I want to get some affect out of you, all I got to do is ask you about your grandchildren. Of course. I know right where to go because I know where it's going to hurt. So I can see, I can get you to react very quickly. Thank you
That's why we
again.
bring pictures in like this.
Thank you again very much.
Thank you very much.
I'll send you the copy.
Yes, and what I will do, I will send it out to our folks who were not here,
Yeah,
so they can actually see it.
I'm sure they have an opportunity to call me.
Yes, definitely. Thank you, sir. I do appreciate it.
How available are you before this? I think individually, we should all ask you questions if we need to.
Relax. You don't need to right now, that's okay. You always know where I am.
Step back.
Take a swallow and deep breath.
Have a cup of tea. That's what my mom said.
If you ever had a
Tea
chance
cup
to
of
check
gin.
out our website, you'll see what we do with this stuff.
Your name is Petrucci and you're learning Italian?
I'm sorry, my grandparents would be sorely upset. I know some Italian, it's not good though. It's not the good words, it's the bad words. Thank you very much.
Thank you.